dressing change kit, use just the plain Tegaderm. You can use 2 plain Tegaderm. They are reacting to something in that white. There's glue, I only can imagine, that holds that white material to the Tegaderm, and they are reacting. So if they react only where the white is, and you send us a few patients that it's very, very noticeable. It's only where the white border is. Where the Tegaderm touches the skin, there is absolutely no reaction.
So maybe an adhesive allergy?
Yes, yeah, it's to that, whatever that is, if they use on that white portion of the dressing. Now remember, they have to have an occlusive dressing, and we do have some patients that are totally allergic to the Tegaderm. That is very difficult for you guys, because you have to have a dry, sterile dressing, and those have to be changed daily. But you can't put any adhesive of any kind. So no problem pulling the pick out. The dressing, no problem. Question, did I answer your question on the port?
Yeah.
Be very careful with your port. If you access a port and you don't have a blood return, what do? Have somebody else re-access your port. Your needle
Certain
sometimes,
feel to it.
I have, because even if you go on the outside, you will feel it's hard because of the way the port is, the slope of the port. So if your needle is coming straight, it's not touching the port, so you think you are okay, you are in the port, and then you feel something hard, and you think you are in the port. So be careful. Do not use a port if you don't get a blood return, because you could be giving it in somebody's chest. I think I
You
have,
just review the port thing, so okay, clean it, I've got my needle, I've got my,
it has to be a non-coring needle,
right,
special needle.
but I'm gonna
It comes with a kit, right?
it has a kit. And then, so don't you flush your tubing before?
Correct?
You got your saline lock attached to it, you push it in, and then you draw.
Correct.
And then when you're flushing it after you do, let's say you give a med or whatever, now you're gonna flush it, before you take the needle out, let's say, you flush it with saline, and then you put the heparin, 5 mLs,
Of
100 units per, okay, and then you end with that. You flush, then you end with your heparin.
Correct. Then you take your needle out.
Yeah. Well, no, it's something you don't do, and then you kind of forget, I know.
In the
Somebody
policy,
wanted me to do that the other night, and she had never done it on 1 East, and I was like, all right, I have to think, put my thinking cap
in the
on.
policy, it says how to access and
Yeah,
deaccess.
yeah.
You see this port? The needle is in the port. And obviously, this is a groin port because the catheter is going up to the inferior vena cava.
Those are rare.
Not as rare anymore.
Really?
We see more and more. This is the same port. See a difference? there's 70 mLs of dye around the port. The needle was not in the port. So when they gave the dye is all around the port.
That's not enough to make sure you have a good blood return. I don't know what is.
Right.
Now, this is dye, that will absorb. If it was my chemo, I would not be too pleased.
Very toxic.
Oh, even Vanco.
Yeah.
And the reason we're seeing more and more groin port is because we have used all the vascular access in the upper extremities. I mean, we do have plenty of veins in the arm, but I have a patient, I have already put 7 picks in the right arm, and I think we've put 3 or 4 in his left arm. So pretty soon, not right now, we all refusing to put any pick in his right arm. So where are we going to go next time? So we are suggesting that they put a port, because a port may last 3, 4, 5 years, while a pick has to be removed every time he's discharged. And now, when your patients have a lot of heart surgery, we are having a hard time to go down, depending on what they have done to the anatomy on the way for their surgery.
I sent it to my nephew. He was born with a half a heart. He's had multiple surgeries, multiple complications, and now they're concerned because he also doesn't have good access anymore.
And you'll see ports in the abdomen, the groin. You'll see your port, if they are placed by a interventional radiologist, they're usually in the jugular. And if they are placed by a surgeon, they're usually in the subclavian. When they are in the subclavian, you have that possibility of the pinch-off syndrome. But when they are placed in the jugular, what you have is a kind of a sharp, the catheter goes and it has a sharp curve. And so sometime, because we used to say, well, why don't they are all put by interventional radiologists, you won't have the problem of the pinch-off syndrome. We have problem just the same. It's a different problem, but we have other, because it makes a very acute curve. And then we don't have any blood draw. But we can flush them. But we don't know what the problem is. A pulpogram, when they inject the dye, then you find out if there is a fracture or if they're disconnected or there's just a sharp curve or what the problem is. But you all love pics, right? I can see that. You have question about the cat flow?
The only question I have is when you have the partial occlusion,
Yeah.
when you're doing the cat flow, are you pulling back like you would be if you were doing the full occlusion where you're letting it sit?
In a partial occlusion, because in a partial occlusion, it may be sluggish, but you can instill it,
Right?
so you just put it in.
Okay. And you're not flushing right away?
Nope, you just put it in, put the 2 ml in there, and let it sit.
Do we need a doctor's
Do a
order for
stand
that?
getting the
Here, why don't we have fun?
Do we need a doctor's order?
You do need a doctor's order.
Absolutely. And please, the order should read, cat flow, 2 milligram for occluded thick port. may repeat time one.
Times one.
If you send us a patient with an order cat flow per protocol, we will not receive the cat flow. I know what the protocol is. What pharmacy doesn't. I mean, they do know, but legally it is not an order. How about we just read the question and answer them? Want to start?
Yes.
The formation of layers of fibrin on the catheter after injection is
B.
It starts almost immediately. Within the first 24 hours, you will already see the fibrin. 2?
If you can infuse solution and even flush the catheter but cannot aspirate blood, you may have a
Partial.
Right. What percentage of catheter occlusion are thrombus related?
It's 8. I mean, yeah.
58%. Diane, the type of thrombotic occlusion that may completely cover the opening?
Of the catheter tip. Like a sock is called a,
Fibrin sheath.
Correct.
yeah.
According to the 2006 Infusion Nurse Society and even the 2011 INS, medication in solution may be administered either before or after aspirating for a positive blood return and confirming patency.
False.
That's false. It should be before, not after. According to AVA, salvage of an occluded catheter is preferable to catheter replacement because
All the above.
yeah, it reduces the risk of trauma, it decreases the risk of complication, and it helps limit treatment disruption. Why is proactive management of CVAD important? All of them. Assessment and proactive care of CVCs are essential to ensure proper function and help reduce the risk of catheter-related bloodstream infection. The INS standards of practice state that catheter site care shall be performed using aseptic technique in observing standard precaution. In the Cool Warren clinical trial, cat flow activates demonstrated 88%. The earlier cat flow is used when treating a thrombotic occlusion, the higher the likelihood of restored function.
True.
There were no intrathecal hemorrhage and no embolic events in either of the Cool trial. That is true. Cat flow should be used with caution in the presence of known or suspected infection. True, because remember, when you break down the clot, whatever is in there will be released. So if you are thinking that there is an infection, that will be released in the bloodstream. In clinical trial, the most serious adverse event reported after treatment were
A.
sepsis, gastrointestinal bleeding, and venous thrombosis.
The eye bleeding. Thank you, Louise.
You're
Yes,
welcome.
thank you.
You have to turn this in?
recommend this.
We'll give it. You want it
Sure.
from Kathy?